Hey fam, happy Friday to you. Oh, I have to say, this week has been exponentially better and nicer than last week because in our household, health is finally being restored a bit and we are getting back to living life. And I love that because not only do I feel like an actual human being this week, 1 point for me, but also we get to discuss cultivating hope and living life for our body dysmorphic disorder warriors. So join me and my special guest, Margaret McCall, LPC, as we discuss this and more. I'm Nicole Morris, licensed marriage and family therapist and mental health correspondent. And let me be the first to say, welcome to the family, the OCD family, that is. I am here to create a community of support for family members, spouses, partners, parents, adult children, as there may be adult words, and chosen family of OCD sufferers and their community. I've had over 22 years of experience in the mental health field, but please note that this information does not qualify or substitute as a diagnostic evaluation, therapy, or treatment, and it is presented on an as-is basis. Please follow up with a qualified mental health provider in your area regarding concerns for yourself or loved ones. Thank you for joining us today. Now, let's get started. Alrighty, fam. Alrighty. I have to say, I am feeling just so much better this week. And I don't think I've ever met anyone who likes being sick. I don't like being sick. But I gotta say, when it's not just you that's sick, but your kiddos are sick, your partner or spouse is sick, my husband was sick, oh my gosh. You can get into this place where you feel this sense of powerlessness to the circumstances, and it really stinks, and it's exhausting. And I know you get it, fam, because for many of us, what brings us together in the first place, OCD or OC-related disorders, also known as OCRDs, they can leave us feeling powerless too, distraught, and alone. But you know what, fam? You're not alone. We are not alone. And that is good news. So today we're going to be revisiting a very important topic. And while I have had this on the books for, gosh, at least a few months now, we are edging closer and closer to the first annual online BDD conference through the International OCD Foundation. So as I was looking at my schedule, I thought, you know what? I want the fam here to know about all the resources available. And that is such a fantastic resource that I just knew I needed to get this episode out to you sooner than later. Now, in the past, the online and in-person conferences through International OCD Foundation has had different sessions, different speakers, different sharing, and even has a whole division on their website devoted to BDD. There's a BDD special interest group through the International OCD Foundation, and that's fantastic. But still, we are short on resources. And so the more information, the more understanding and awareness, the more research, the more everything that we can get on the subject, it is really important and it really matters. So we're going to talk more about the BDD conference and other resources available toward the end of today's show. And I'm going to be, of course, posting all of the details on this episode's blog over at OCDFamilyPodcast.com because you know what? I've got you, fam. I've got you. I know how we listen to podcasts, and we're usually doing something else as well, so we're not sitting there like a secretary taking notes, and that's okay. You do you, and I will put it all on the blog. You can find it at any point. But for now, I want to talk to you a little bit more about our esteemed guest, Margaret McCall, LPC. So Margaret is a licensed professional counselor in the Georgia area here in the United States, and she specializes in OCD and BDD. She has been practicing I-CBT for over 2 years now, so I-CBT, Inference-Based Cognitive Behavioral Therapy, and she trained under the man himself, Dr. Frederick Ardema, one of the co-founders of I-CBT. Now, you may recognize that name because not only is he a co-founder of one of our evidence-based treatments, but he also was here with us, fam, at the beginning of season 2. And really, the dissemination about this evidence-based practice, I-CBT, has really been growing quite a bit in the United States as of late. So while I had never met Margaret prior to our recording for this episode, I have seen her around our shared treatment spaces, and as you'll hear me say at least a couple times over before this episode's finished, she has been a huge cheerleader for the fam. I found her sharing our episodes, the insights about the episodes, and the stories of hope that we discuss at our family table. And it's so appreciated because with her sharing comes more awareness, and with more awareness comes more resources and hope. So I am so excited to get a chance to break some peripheral bread with her here today and hear more about her use of I-CBT and the application of I-CBT when it comes to the treatment of BDD. Now, I just want to say I-CBT really started to be more on my radar as an additional evidence-based practice and gold standard for the treatment of OCD in late 2022, but it's been around for a lot longer than that. And I've only ever used I-CBT in the application of OCD. But I've known a Margaret and a few others actually that have started using and applying I-CBT for BDD as well. But to be quite honest, I really only know a small handful of professionals, period, I-CBT or not, that are treating BDD. And that's sad because it's a real disorder that is incredibly distressing and real hope is needed for lived experience warriors. That's partly why every time that I have an OCRD series, I will feature different OCRDs, but BDD, without question, is always one of the featured discussions every time. And guess what? It'll continue to be because we need more information, more resources, more practitioners, more research, and more hope for this part of our fam. So I'm going to link to Chris and Liz Tronson's interview with me last year and Robin Stern's episode from this year's OCRD series on BDD over at the blog as well, because again, I just want to have as many resources available for you fam as possible. Now, I've worked in this field a good 20 years before I ever learned more about OCD. And during that time, I've learned a lot of different evidence-based treatments. What I've learned, particularly from within the CBT framework, is that there are a lot of different modalities within CBT that are used to treat very different things. For example, dialectical behavioral therapy, that's also known as DBT, is different than trauma-focused CBT, is different than CBTI, which is a multifaceted treatment approach for insomnia, is different than exposure and response prevention, that's ERP, is different than Inferenced-Based CBT, that's I-CBT. And certain treatments are indicated for certain presentations. But as we have found, for example, in the ERP treatment world, which is one of our, again, gold standards for OCD, is gosh, this can be a really effective treatment model when we're looking at eating disorders or substance use disorder or specific phobias like emetophobia. Additionally, treatments like DBT can be really helpful for borderline personality disorder, cases where there are high-risk behaviors or self-harm, substance use again, depression, anxiety, and even OCD. In fact, recently I had guest John Hirschfield here with us, fam, and he came out with a book, I think it was within the last year or so, called The Unwanted Thoughts and Intense Emotions Workbook. And if you've read this, if you have a copy, I have a copy. I think most of my colleagues have a copy. This is really a pairing of CBT and DBT skills, again, to help with the management of intrusive thoughts, emotional dysregulation, big feelings, you name it. We've talked about RODBT, being radically open dialectical behavioral therapy. In fact, Erica McCoy was on the show recently just sharing her story about her lived experience of OCD and trauma, and she really discussed a lot of aspects of how RODBT was so helpful for her. And so we as clinicians, as we learn more of these different treatment modalities and start to understand them more and the mechanisms of what make them tick, then we have the ability to see the corollaries. We can see the overlaps. We can see how DBT can be helpful as well as ERP, as well as I-CBT. And so today we're going to be having a discussion about the application of I-CBT for BDD. Now, this may stretch some folks, particularly here, again, in the US, where I-CBT is newer to a lot of us. Worldwide, it's been around since the 90s, but in the US, it is really just kind of coming on the scene in a grassroots way. So already, maybe your comfort level is, I don't even know about I-CBT for OCD, let alone for BDD. How does that work? These are different mental health disorders. And you're right, they are. They're different. And I want to validate that. I'm also coming into this conversation not knowing what to expect. We're going to learn together, fam. But just as it were with OCD, and my approach to this is, hey, if it has the evidence to show that it works on this mechanism or that, and it can be applied and provide hope to our lived experience warriors, then I want to know more about that because I have a goal of expanding hope. So I'm willing to have the conversation, and I'm actually really intrigued to see how it applies. And I hope you will be too, because my entire goal here, fam, to be utterly and completely transparent, is to provide you with hope, support, and resources where we can learn more, where we can know we're not alone, and where we can help champion our warriors so that they can get back to living their lives. So that brings us to Margaret, and I have to say I'm excited because I'm a big fan of all those things. And I'm really curious about how this applies. So I think the key here is going to be understanding why it can work for both OCD and BDD and potentially other things. But lastly, I just want to provide a brief trigger warning as well. I think it's really, I don't know, I think it's almost impossible to talk about BDD without talking about suicide, and that is heartbreaking. But BDD is heartbreaking. It's a crushing and cruel disorder. And I think it would be an ethical error, really, to leave out that the suicide rates in this population are high. And that is a big reason why it is so important for us to cultivate as much hope as we can, strength, resources for our BDD warriors and family. So while we won't go into explicit detail, I just felt it important that we shed some light on this reality. But the good news, the great news, is there's hope, fam. So without further ado, let's get to chatting because hope's on the horizon and I want you to hear more. Well, welcome back to the OCD Family Podcast. And one of the things I just have to say, not only am I excited to have Margaret here today, but you have been such a cheerleader. And I've said this to you so many times for the OCD family community and just supporting the information on a myriad of different topics and resources and themes and modalities. And so I want to say a big thank you as well. And I really appreciate you.
Oh, you're welcome. I really enjoy listening to your podcast, and I want other people to hear them too, so I have to promote them.
Oh, I love that. Well, thank you. We do appreciate the support, and we're better together, and you're part of that. You're part of the fam, Margaret. So today we're going to be talking about one of our OCD related disorders. If you're newer to the podcast and you're like, what is BDD or how does that relate to OCD? We're going to get there in a moment. But first of all, because I came to this field and this specialty later, I had a different emphasis and a different specialty prior to OCD. I've been really interested in talking when we have colleagues, friends, researchers on about how you came to treating OCD in the first place. So I would love to hear that story, Margaret, if you're up for it.
I'm very similar, Nicole. I have two phases to my career. The first was residential treatment for troubled teenagers. Then I took a break for 10 years and became a stay-at-home mom. And when I came back into the field, I decided to go into private practice. Now, I didn't say this before, but I have OCD in my family. Like I'm surrounded by OCD. I don't have OCD, but I've certainly had inferential confusion, which we're going to talk about today. But I got my first client. I recognized OCD. I didn't know how to treat it, and I didn't know that I needed to be a specialist. I started doing my research. I bought Edna Fola's book, and I said, I can refer you to someone else who specializes, or we could try this. With the manual in my hand, what I didn't know at the time is I was the only OCD specialist within a 100-mile radius. I could not have referred her out to a specialist. I was good as anybody else. So we did. This was 8 years ago.
Yeah.
We treated it with contamination OCD. I heard from her a year ago and she said, I'm still doing great. I still appreciate the treatment. She responded really well. It was ERP. We went through the steps. It's a very manualized treatment. So it worked. And then over the course of the next few years, I treated a few more. I always enjoyed it. I used the same principles. If I got stuck, I would research. At that time, we didn't have the OCD Facebook group so that we could get consult with each other. And like you, in an area where there's
Yeah.
no one to ask questions of. And so I just did my own research and treated it. And then the pandemic hit.
Yeah.
And then it was like every other client I got had OCD. They didn't know it, but I recognized it. And I realized, oh, there's so much more I don't know because I started seeing different presentations I'd never seen. So I signed up for training at UPenn. This is in 2021. But at that point, I had already researched and trained and did online, YouTube from the experts. So I knew a lot already and I had been treating it. But I signed up at UPenn and had the intensive training for OCD. I went on and got my certification in ERP. and continued for the next year treating OCD, moving towards it being all I treated. But I had some clients with other issues that I was still treating, but this is my specialty. This is what I'm treating. And then a year later, I learned I-CBT. Game changer, right? As
Yeah.
many of us know, and joined the Facebook group right in its beginning with many of the other people who've been doing this for a couple of years.
Yeah, well, I am interested in how people get into OCD because I'm guessing most people that get into BDD, unless they have lived experience and are just painfully aware of BDD already, most people learn about BDD once they get into the OCD world. And it sounds like that was the case for you. So I would love to hear actually how BDD came on the scene from your getting into the OCD treatment community.
Right, right. So I knew there was a diagnosis of body dysmorphic disorder. I knew that was in the DSM. I was familiar with it, but I
Hmm.
wasn't trained in it. I didn't have a lot of information, kind of like OCD. I was one of those therapists who didn't realize that you needed to be a specialist. I actually have taken that experience and I train local graduate students at local universities. Every semester, I'm in their psychopathology class and train them as a guest speaker on OCD and how to assess it. So they don't look back. Like me, I look back on the years before I became a specialist. I know there were many people I now like, oh my gosh, that I've actually reached out to former clients and say, I think I misdiagnosed you. I'm pretty sure this is OCD. If you want to go back into treatment.
Yeah.
But with BDD, I really didn't know enough to diagnose very well. And I didn't know how hard it was to diagnose, not because it's hard to diagnose, but because people with BDD won't tell you about it,
Right.
right? So I wasn't all that aware. And then about the same time I was learning I-CBT, I had a couple of clients who I recognized had BDD. It was clear to me at the time, started using some of the more traditional approaches, and it wasn't going all that great. But again, I was a new practitioner at it, so I'm sure I was making errors. And then I learned that I-CBT could be applied to BDD. And I thought, well, I've really diving deep into this I-CBT and training. Why not try it? And I had 3 clients with BDD.
Mhm.
One of the clients responded very, very quickly and basically told me she didn't even understand what I had done to her when we got into module 3, about 2 weeks after module 3. And I was kind of shocked too. I didn't realize that BDD could resolve so quickly. And it really blew me away when I used it. Now, that was one client. I had another client, a teen, probably the most severe OCD case I've ever treated. And actually, both of these clients have given me permission to do a presentation on their BDD. And you can go to the I-CBT website and hear their story of treatment, actually. So the other client that I treated was pretty severe BDD,
Mhm.
but after about 3 months, I mean, I started to see progress right away. Each week we were making a little bit of progress. Again, I wasn't that trained in BDD. So
Right.
I was just following the modules and doing my thing, but her BDD was focused on her nose and she wore a mask in every session, which we did virtual sessions. And that was March. By July, she was no longer wearing a mask and then actually got a nose ring.
Wow.
Right, right. So she had had BDD for several years. She didn't know she had BDD, but she had had it for several years. And because she had had it at such a developmental phase of her life, she had missed out on a lot of growth
Right.
and learning, right? So
Right.
social skills, interpersonal skills, a lot of avoidance. And so we spent another year just working on those things,
Yeah.
but she was no longer worried about her nose,
Wow. That's
which is what,
powerful.
yeah, it's what ICB treats. It treats the actual perceived flaw, imagined flaw.
Okay, so there are a lot of different points that we can discuss within there. And so I'm going to bring us back, but I really love hearing the story of how you got into treating. And so a couple quick little things. I should make like a OCD family dictionary for any of our new fam coming in because sometimes it sounds like alphabet soup and it's like, oh my gosh, what? We have OCD and OCRD and BDD and ERP and ICBT, right? Okay, so if you're new to us, fam, you're welcome here. If any of that didn't make sense, hang because we are going to discuss it all. Okay, so Margaret shared she started with treating OCD with ERP, that's exposure and response prevention, one of the gold standards for treating OCD. She's also referenced I-CBT, that's Inference-Based Cognitive Behavioral Therapy, and also decades of research and an evidence-based practice for the treatment of OCD. They treat OCD very differently. And one of the main pieces that we are going to get into is discussing the direction that I-CBT takes is not just to treat quote unquote OCD. What it's treating and targeting is something we call inferential confusion. And so we're going to look at the role of inferential confusion, what it is, and how Margaret, in her work, just as you heard as she got into BDD, started to recognize inferential confusion when it comes to BDD is also something that we could target as a mechanism that is actually making quite a difference, at least in Margaret's caseload, but also we'll talk a little bit about research. Also, I want to talk about some of you coming in today are going to be like, what? I don't understand what BDD is and what does it have to do with the nose. So we'll start with discussing what BDD is. We will get into then the piece where Margaret treats using I-CBT, which is in the title of this episode. So you're probably aware like I-CBT is coming up. But I-CBT traditionally, at least here in the States, hasn't been a main treatment consideration even for OCD, let alone BDD. So we're going to talk about the inferential confusion piece and why Margaret's been able to find that inferential confusion can be treated within BDD. Also, you talked about different modules. So within I-CBT, there are different modules, fam, that treat different steps. It's also a manualized treatment, an evidence-based treatment. And so she talked about BDD resolving within Module 3. Now, some people tuning in, maybe folks with lived experience, or you're well aware BDD is wreaking havoc on your loved one, on your partner, on your child, on your parent. And so I think sometimes the word resolve, or when we kind of look at and conceptualize BDD, you might be like, I don't feel like that's congruent. I don't understand how something could resolve like this. We've been living the wreckage of that. And so we're going to be discussing a lot of different elements. But I hope, especially if you're a person with lived experience or a family member of someone with BDD, what I hope we can do is have a conversation. We don't have to agree on the best way to treat one thing or another, but what I am a fan of is if there can be more hope for BDD sufferers, because we can see how this relationship of inferential confusion and how that can play a role in BDD, then that's more hope. And so I really hope that you'll stick with us as we continue to discuss this, because it's not my first time learning about I-CBT, but it's the first time I'm learning about I-CBT in the application to BDD treatment. So I'm learning along with you guys, and I am excited to learn. And so why don't we start with, what is BDD in the first place? What is body dysmorphic disorder? We've heard something to the effect of maybe it can involve the nose and the nose ring. It can involve perceived flaws. And so let's talk about clinically, when we say BDD, what are we talking about?
Okay, great. So, body dysmorphic disorder
Yeah.
is a disorder that is characterized by preoccupation with an imagined flaw or defect, or several imagined flaws or defects in a person's body or face, most often in the face, or it might be a very slight defect that other people wouldn't notice from a conversational distance. So the person would have to point it out to you for you to be able to see, oh, yeah, you do have that little tiny mole on your forehead or whatever. Now, I want to clarify, when I say imagined, a person with BDD does not believe it's imagined. When they look in the mirror,
It's
they
there.
see the flaw, things are distorted. And there are research studies that show, fMRI studies that show a person's visual processing. There are differences in the brain with a person with BDD, right?
Yeah.
Now, there's theories about that. The theories may be that they're born with this visual processing disorder. Other
Uh-huh.
theories think maybe the BDD caused the visual processing issues. We don't know for sure. My hypothesis is that the BDD, the constant looking in the mirror, things get distorted. I personally believe that a person is not born with it, but the BDD is causing it. And we're going to talk about more about inferential confusion and how that can confuse a person what they see, right?
Yeah. And visual processing, I've been very open with the fam here because that's how the fam does it, right? We keep it real. keep it real. And I have autistic family members, and they have different ways of processing things. But I would say, even within my children, we've done things like occupational therapy to integrate some of those sensory pieces. And so a sensory processing thing isn't something that you can will or create. It's something that we start to see how the brain is responding. And what you're talking about with those fMRI studies, if I'm understanding it correctly, is that in studying BDD patients or clients, it is registering a visual processing change. This isn't an imagined psychological, we talked with Robin Stern earlier this year, and she was talking about the frustrating piece of talking about dysmorphia, right? Because dysmorphia is kind of thrown around, kind of like intrusive thoughts can get thrown around and sometimes have nothing to do, but kind of take information away from what BDD people are suffering with. And so what you're sharing about is when we use words like perceived or imagine, literally, if we go to the brain scans, there are some visual processing differences. And
Exactly.
so I think that's a really helpful clarification, because sometimes, fam, you may even be sitting there going, oh my gosh, I've done this too. But you might be like, oh, come on. It's whatever you're thinking is not there. Get over it. It's not a get over it when it is a reality when you're looking at the MRI and you're going, oh, yeah, no, the way they're processing this is different, period,
That's
right?
right. That's right. And, that's a good point you brought up about dysmorphia versus body dysmorphic disorder. In order for a person to get a diagnosis of BDD, they have to have that first part that we just discussed, right? But they also have to have other criteria. So, first of all, there has to be that preoccupation. It has to occur for at least an hour a day. It includes compulsions, which can be mental. They don't always have to be physical, but the most common compulsion is mirror checking. There's reassurance seeking. There's a huge component of avoidance. So we're talking about this perceived flaw, this imagined flaw. It's distressing. It's very distressing.
Yeah.
It takes up more than an hour a day, and it interferes with a person functioning in life. Like there's impairment in school or in social life and family life and work life. So all of those criteria need to be met. It's not just, oh, I feel not so great about my body,
Yeah.
right?
Yeah, no, it's a really great point, because whether we're talking about OCD or BDD, we need to not miss the forest through the trees on the D, disordered, right? It's exactly what you're talking about. The medical model speaks about it in terms of functional impairment, right? But the reality is, and it's part of the rub, I think, when someone says, "Oh, I'm a little bit CD," or "Oh yeah, I have some dysphoria," or whatever, it downplays the disorder. We're not talking about this. It's something I feel insecure about, and it rubs me the wrong way every so often. We're talking about this affects the way I live at home, I work, I do school, I have social relationships or not, because of the level of pain and the dysfunction that this can bring to my life. Like, I can't move on if I am caught at home feeling trapped, because what I see in the mirror, in the case of BDD, mirror checking, like you said, can be a big element of it. And that can happen for OCD as well, where we can feel trapped at home. And on the outside, we might go, oh, well, you kind of have some anxiety about going out of your house. But the anxiety, the distress is born out of this disorder. And so we don't want to miss the forest through the trees. You can't be a little disordered. It's impairing your functioning or it's not. And so you're really speaking to that piece of when we conceptualize what is disorder, it's going to range for different people. And we don't want to minimize their experience. But generally, when we go through and we screen for some of these things, yes, we're seeing that it's at least an hour of the day where you're feeling this affects your ability to engage in your value driven life, right? And so BDD is a very serious disorder that does not have a ton of information. It gets kind of included under the OCD umbrella. But part of why we're talking today, fam, is we actually have, through the International OCD Foundation, a BDD conference coming up. And so we wanted to share this information with you before that happens, so that anybody interested in going and learning more about BDD has that resource. Because depending on where you are in the world, not just in this country, in the United States, but in the world, you may not have a lot of access to information about this. And so that's part of why we wanted to talk about this today. So now, when we think about BDD, and a lot of the research shows, I'm thinking because both Chris Tronson and Robin Stern were on the show with me in the past. Chris was on last season, Robin was on this season for my OCRD series. And one of the things that we talked about in my looking at the research too is this rarely comes up in the therapist's office. Generally, where you're going to see a lot of people taking action to cope with BDD, you're going to be at a dermatologist's office, you might be at a plastic surgeon's office, you're trying to rectify what this flaw is, because again, your experience of it isn't a perception, your experience of it is it's there, it is. I am grotesque, I am flawed, I am this thing, right? One of the things that Chris and Robin and I have discussed is it's a very egocentric, very involved with self. But also, Margaret, as I have started to go through the process of even having you come on and share about I-CBT today, you also have spoken to, yes, how this is a very personal, again, when we're looking at ourselves and how our brain is processing what we see, it feels very, very personal. And it again validates speaking to that egocentric nature, the cruel egocentric nature of BDD. And so I would love to then pivot and start to think about, first of all, what is inferential confusion and why does it make sense to conceptualize BDD as also having this mechanism of inferential confusion? And it's a dense concept, so we're going to do our best to kind of have a drive-through conversation on that, because we could have like we could have many, many conversations on inferential confusion. It's a meaty concept, but would love to hear more on that.
Yeah, it is a very dense conversation, and I will try to do my best to give it justice. So I'm going to back up a little bit.
Yeah.
And the way Inference-Based CBT was first developed, it was for people with overvalued ideation. It was to treat people with obsessive compulsive disorder who really believe their intrusive thoughts or their doubts, whatever we want to call them. And an inference is a conclusion that we arrive at based on evidence and reasoning, right? So
Yeah.
whenever we're making a decision about something, we have a question in our mind, we are reasoning and coming up with possible conclusions. We think about personal experience we'd have related to that. We think about things we've heard. There are rules society has. So an inference is a conclusion we come to based on evidence and reasoning. When we have inferential confusion, that means that we have come to the wrong conclusion based on faulty reasoning. And this is a human problem. This is not just an OCD or a BDD problem. It's evident in research where they come to faulty conclusions based on wrong information, right?
Right.
And so, how does that relate to BDD? Well, back up just a minute more because we are arriving at a conclusion based on faulty reasoning, and we are relying more on possibility and imagination
Mhm.
than we are in the evidence right in front of us, right? So, the definition of body dysmorphic disorder is an imagined flaw. ICPT actually fits very beautifully in that concept. And when I treat someone with body dysmorphic disorder, we look at and we address the actual doubt that they're having. So, for instance, if a person comes to me and says, I think I'm ugly, I'm grotesque, I'm defective, I'm going to ask them, what about you makes you ugly, grotesque food? What are you looking at when you look in the mirror? What is this? And if they tell me, well, one eye is higher than the other, or my eyebrows aren't even, or my nose is crooked, or my jawline is asymmetrical, whatever that is,
Yeah.
that is the primary doubt. Now, I'm looking at a person who I do not see this, and anyone with BDD will tell you when they try to seek reassurance, they do not get validation for their doubt. They're often seeking reassurance because they are seeing this in the mirror, but nobody will tell them. And of course, people are just nice, right? Where they're not going to be mean to me. And so they can kind of rationalize that as they just don't want to hurt my feelings. But they will find even in themselves, most of my BD, actually all of the clients I treat with BDD will tell me that sometimes when they look in the mirror, they don't see that flaw. Or they'll look in the mirror and feel like that everything's okay, not great, but okay. And they walk away from the mirror and the image they have in their head draws them back to the mirror. Because how can I be sure, right? So when a person has come to a faulty conclusion, they are inferentially confused.
Mm.
And then that doubting process starts building, and then they gain other evidence. There's a huge piece of confirmation bias, which means that they are looking for other pieces of information that confirm this doubt that they already have.
Yeah.
So what starts out as this doubt, it's not very strong over time, builds and builds and builds. Nobody wakes up one day, has an intrusive thought that their nose is crooked, and all of a sudden has BDD. But they get the idea, maybe somebody said something, maybe they heard a conversation about somebody else, and they started thinking, well, I wonder if my nose is like that. And then they start looking and doubting and looking for more information to confirm it. And BDD grows over time. It typically begins in early adolescence.
Mhm.
And I think the research shows that like 4% of college students have BDD. Now, in the general population,
Mhm.
it's 2.7%, very similar to OCD. The numbers are very similar of people who have BDD, but a large percentage of college students have it if you look at that population.
So one thought I had was I remember when Katie Merritt was on the show and she was talking about I refer to her as one of the foremothers of I-CBT here in the States just because she was one of those early adopters, as were you, Margaret. But one of the things she quoted when we chatted here with the fam, and I'm going to mess it up because I'm not going to remember it exactly, but she quoted Mike Hetty when she was learning about I-CBT, talking about it's a situation where there's that over reliance in the imagination over what's happening here in reality. And so, as you were talking about that over reliance in the imagination, it just kind of had that ding, ding, ding. And I was like, hey, yeah, because I mean, we were talking about I-CBT for OCD, but like you said, if there is also that element going on within BDD, then we could see how, yeah, there's an over-reliance in the imagined, which just like in OCD, somebody with BDD will tell you, I'm not imagining, it's there. It's like it hits,
Right.
as Mike has told me before when we've talked about ICBT, it hits you between the eyes, right? It is so common sense for you, right? And so one of the things though I also think about when it comes to BDD is if you're looking in the mirror and if we look at the brain scan of someone suffering with BDD and it's like, yes, the visual processing is different. We can look at the fMRI and see that it is different. How do we sort out when it's an over reliance in the imagination and when it is reality? Because for the person with BDD, they're not going to be able to distinguish that, right? And they're probably not gonna come out and be like, "Hey, do you see this thing that I'm, like, so hold so much shame and disgust about?" They're probably not. Most people aren't like, "Hey, look at the cellulite on my thigh, it's amazing." And that's just an example for me. I'm not saying that's how the BDD person would sound, but it's just a point that I'm not gonna draw people to some of those discretions. So how can we know sometimes if it's an over-reliance for the individual sufferer? How does someone know if their brain scans are like, it is the same virtually?
And that's a great question. And it's a really good question for the listeners to see. A person with BDD just sees what they see and they don't doubt it, right? However, if you know something for certain, there really is no reason to check, right?
That's a good
So if
point.
you are spending hours in the mirror and then having to go back and check, a person with BDD will recognize themselves in the compulsions probably more in the imagined flaw, right? And a lot of people, you're right, they don't seek reassurance. So they're not getting information if they're seeking reassurance, it's typically with very, very close people like family members, right? But not friends because they don't want to draw attention to this and they don't want to appear vain and for other people to think they're just all self absorbed. Unfortunately, there is a lot of self absorption in BDD. It's not who the person really is, but the BDD takes over and makes them become self absorbed. But if a person's looking in the mirror for hours a day, they are obviously doubting something.
That is such a hopeful point. Thank you. Because I was thinking, like, but how would you know the difference? And you would see the difference in how it's functioning And similar to in the OCD world, I remember when I was going through the BTT, I got amazing resources. In fact, I'll put it on this episode's blog, along with links to all this information, links to this BDD conference coming up, links to Margaret, so you can learn more about her, and I-CBT.online, where you can hear those stories that she had the permission to share when it comes to BDD. But it is interesting because one of the handouts I received was, and I often would give to clients, is the difference between reassurance seeking and information seeking. When I'm given information, even if it's information I don't like, chances are I'm not just doubling down and being like, but really, but really, but really, but really. Where reassurance seeking is not satisfied with the
Right.
answer, good answer, bad answer, anything in between. The compulsion is, but what if it's wrong? What if they didn't evaluate all the facts? What if I misunderstood it? What if, it could be so many different
Mhm.
pieces to that. And so that is really helpful. We can see the difference in how that functions. Because I haven't checked lately, to be honest, Fan, but I'm pretty sure, and not just for me, but for a lot of us, yep, the cellulite's there. Right? And I'm not trying to state that cellulite is what BDD is. I'm just using it in an example of what I could say as a vulnerability as an aging woman, whether it's wrinkles or cellulite, whatever. But, when it comes to BDD, and you were talking about the prevalence on college campuses, I also think this sometimes can get confused with eating disorder, as we're learning. And eating disorder is also something that can run pretty rampant on college campuses as well, and can have integration of how you see yourself and what you're seeing when you look in the mirror. And so, can you also help us distinguish the difference of BDD from eating disorder, just for any of our family here that might be a little confused on what the difference is?
Yeah, absolutely. And it's a really important point. And sometimes it's not so simple, right? When I'm trying to figure out, is it a weight concern? Is it an eating disorder? I've had clients who have eating disordered behavior that had BDD because they were trying to restrict calories to alter a specific flaw, like an area of their arm or their stomach. They weren't worried about their overall weight. They were trying to reduce the size of their stomach because they felt it was out of proportion to the rest of their body. That is body dysmorphic disorder. But if someone's not familiar with the two, a clinician is not familiar, they're going to treat it like an eating disorder, right? But it's not an eating disorder. It is BDD. Now, a person who is trying to restrict calories for their overall weight and they see their body is larger than it actually is,
Mhm.
and they're doing those behaviors to restrict calories, that is an eating disorder.
Yeah.
So
Mm.
you can see it gets tricky, right? You really need to have at least a working definition of both of those and be able to, you don't necessarily have to treat both of them, but you need to understand the differences and how they show up in order to determine if it's BDD. Does that make sense?
Yeah, it does. So if I were to summarize, because I know I'm hoping to discuss it at least one more time before our long form content of season 2 wraps. But eating disorder too, sometimes you can be a person what society would consider thin. You can also be a more full figured person and still have an eating disorder. But part of the disordered eating is the preoccupation is with the weight. The preoccupation is more meta, like the overall
Mm.
size, right? BDD tends to zero in, and it can shift around different concerns. It could be a nose, it could be the way my jawline looks, it could be hair, it could be the definition or the tone or the lack thereof, and how that is appearing on the stomach, where we might go, okay, that's that we think that's eating disorder, but actually what the problem is, how this is specifically looking, it's really kind of more zoomed in, and it's that preoccupation with that part of the image of what they're seeing versus the overall weight or pounds or size, right? That would be kind of a
Exactly.
more general. Yeah.
Mhm.
So the preoccupation is there. And another thing that you touched on is how absorbing and self absorbing BDD can be. And to me, another little light bulb that went off for me is when I conceptualize inferential confusion. We talk a lot, in my only experience with I-CBT and application is in OCD thus far, but we talk about the OCD bubble, right? And so I would imagine we could talk about OCD bubble because we're treating OCD, but I would imagine this bubble concept is still what it is when we're talking about BDD, a BDD bubble. And so for family that might be newer to the concept of inferential confusion or I-CBT at large, can we discuss what that self-absorption, some of the characteristics of self-absorption and what we mean? Because sometimes in culture today, we're like, oh gosh, they're so self-absorbed, and that means something completely different, right? Than what we're talking about and when we're operationally defining absorption within I-CBT. So could you help clarify that for folks too?
Yeah. Yeah, that's a really good point. And you're stretching my brain a little bit too today to be thinking about this. So when a person is getting ready to go out, people with BDG will often wake up hours before they have to get up to go to work or to go to school because they need that time to prepare. So they're spending 3 hours in the mirror, either doing makeup, and some people are not even putting on makeup. They don't want to wear makeup, right? If they have BDD, but they're spending 3 hours in the mirror for something that might take us 20 or 30 minutes. That looks like self-absorption, and if a parent or a spouse sees them, they may even think they're so vain. But this is not vanity at all, right?
Mhm.
And during that process of looking in the mirror, they are in the BDD bubble, right? They are absorbed in their imagination, imagining all of these flaws that they have on their face or their body and imagining all of the consequences of what would happen if they go out in public without covering it up or making the best of it. So it definitely is. And I know Carl Robbins has been on here and talked about imaginal absorption. He's the master discusser of that.
Yeah.
But that self-absorption is really about being absorbed in their imagination.
Yeah, I like that, and I think you did a great job explaining that because I think even within the OCD context when we're applying it, and again, that's going to be my default fam because that's how I'm used to applying ICBT. But when we talk about that bubble, the allure, the illusion that OCD creates is that this bubble is where you're going to be safe and you got to do all these things to be able to not be this person, this feared possible version of yourself. But the lie is actually getting absorbed into that bubble is what keeps you trapped in the imagination. And in the imagination, all bets are off. So, yes, all the good, bad, ugly can be present, right? And it's actually that bubble that isolates you from reconnecting with what's happening right here, right now in reality. And so, when you're talking about that self absorption, it really is, again, speaking to that piece of if I get ready for 3 hours, I'm probably still gonna feel like, for lack of a better word, fam, shit. I'm gonna feel like shit going out of the house still, even with the 3 hours of prep, right? And probably, I would imagine, as OCD sufferers would as well, but BDD sufferers are gonna be like, I don't feel prep for shit, right? Like I'm still terrified, but it's the bare minimum that I've got to do to be able to go engage in society, to function inside or outside of the home. And that's where we go back to that disordered functioning piece. And so, one of the really important pieces of understanding is where we think if I didn't do those 3 hours, I definitely couldn't do this. When we look at least OCD through an ICBT lens, we learn actually it's when we get out of that bubble that we can live life and live to our values. And so for BDD, then, it sounds like because that's how ICBT functions, that is the hope, right? Can we talk about then what does, and we're going to do a drive through version of it, but what does treatment then look like if we go, okay, this idea that inferential confusion is at play for folks living with BDD? What now then? What do we do with that? And what is treatment going to look like when we consider ICBT as a method for hope?
Yeah, I love talking about treatment for BDD with ICBT. So the first thing we're going to do is slow everything down.
Yeah.
You know, a person with BDD or with OCD, often it's like trigger, compulsion, trigger, compulsion. They don't even recognize that there is a doubt in between there. And so we slow it down. We do a very good assessment. We do the screening to make sure this looks like BDD. We do the Y-box BDD, which is a tool that we use to assess for the severity. There's the appearance anxiety inventory. I do both of those just to be tracking. And then I do the inferential confusion questionnaire. So we get a really good understanding of the BDD doubts, right? And the sequence is the same. There's a trigger, maybe it's looking in the mirror. Then there's an obsessional doubt. My nose is crooked. And then the consequence of the doubt, I'll be judged by others. People will think I'm ugly. Nobody's going to want to be my partner. I might not get promoted. And for some, which is a really interesting concept, they're not so worried about how other people perceive them. They're more worried about exposing other people to their deformity, their flaw. They feel guilty that other people have to see them, right? Which
Yeah.
is sad.
And
And
Margaret, I'm glad you said that because one of the things I was thinking is like part of the problem is they feel like this is them though, right? This is
yeah,
them. So when you're like, how are they gonna see that? It's like, no, they're gonna see me and I'm gonna be exposed.
that's right.
Right. So I'm glad that you included that because from my conceptualization of BDD, I would imagine that is the bigger driver of the problem and distress there.
Well, I'm going to tell you a story. This week, I was going to an in-person consultation meeting, right?
Uh-huh.
And I have a fever blister this week. And so on the way there, I'm thinking at that point, it was Tuesday. And I'm thinking, "Ah, this is so gross on my face." And I wasn't thinking about how people were going to judge me. I thought, I'm going to be grossing them out with this fever blister on my face, right? And all this is going on in my mind on the way there. And then I had this thought, man, that must be what it feels like for people with BDD. That they're going to show up because they see themselves as gross and they're going to be grossing other people out. It's not so much worried about people judging them. They're
Yeah.
worried about how they're affecting other people.
Yeah, I think that's a really helpful insight. And then also you add on that thought not stopping, right?
Yes. Right. I know I have a fever blister here, right? And I know it's going to go away in a few days. But if it's an imagined flaw and it's part of who you are all the time,
Yeah.
it never goes away.
Yeah.
Right. It's
Yeah.
really bad.
Yeah, it's well, and you can then hopefully have empathy for just how debilitating that would feel if you constantly, if living, breathing, engaging in life felt like a constant exposure. I'm exposing myself.
Yeah.
It gets confusing because we use exposure and exposure therapy for exposure and response prevention. It's a different kind of exposure, but it's just like you're living that vulnerability. We're all living vulnerabilities in different ways, but it would be different if you're like, I am living life fever blister style.
Right. And that's why, because life is an exposure with someone with BDG, they often avoid life. And it
Yeah.
becomes debilitating, right? It becomes very lonely. And as we know, the more isolated you are, the more your thoughts are there, the worse it gets. It builds and progresses.
Yeah. And one of the things that we've talked about, and I'm going to reference this on this episode's blog too, just because I think the more resources we can point to, the better. But my episodes with both Chris and Robin and talking about suicide rates and just the
Yeah.
amount of hopelessness that can build for folks. Because, like you said, if you're not living and engaging in life, and I think that was a really powerful way of framing it, and you are isolated with those thoughts and the thoughts are constant that I am this disgusting distorted human being, we can empathize with not only how debilitating it can get but why there are it's heartbreaking but so many cases of suicide or attempted suicide even within this population, which is why it's so important for us to have these discussions. And part of the issue here is the person isn't going to be, as much as they may have their compulsions to try and cope with it, they're not going to come out and be like, hey, doc, hey, therapist, let's work on this. Instead, again, it's something they're going to try and quote unquote fix. And this is where we have people end up in dermatologists' offices, we have cosmetic procedures, and it's devastating.
Yeah.
And so, one of the things you and I were talking about as we came together today before we recorded, we were talking about the importance of screening for this because it's probably not going to just be offered out. They're not probably going to come into the office and be like, I'm here to work with my BDD. Unless they already know they have BDD and they are actively working on it, they're probably not going to have that insight. And these can be extremely, amazingly smart people and creative people and amazing people. It's not about that when we're talking about the insight. Because again, if we look at the brain scans, they're like, I am this, period. There isn't a doubt there. It is the reality that they're experiencing. And so, how do we A, screen for that, and then B, because re-engaging in reality is such a strong piece of I-CBT treatment, would love to kind of go in the direction of, I know this is what you're experiencing as your reality, but also here is reality and here's how we can get some more hope and life back, some
Yeah.
value-driven engagement back. And so I know that's a compound question. We'll start.
Well, let's do it.
Yeah,
So,
let's do it.
uh,
Thank you.
so
You're
for,
so gracious.
so for clinicians, when you have a client in your office that has OCD that you've identified, you'd have social phobia, major depressive disorder, all of those are comorbid with BDD. You want to screen, honestly, every client with a good screener because they're not going to tell you. It's not going to show up and they're not going to bring it in a conversation. If they don't know they have BDD, why would I talk to my therapist about a flaw? Be a dermatologist. So I think as therapists, we need to do a really good job. It's as common as OCD. So you need to be screening everybody. And if you're using a structured interview and assessment, most of those have a BDD screener. If not, the BDDQ is a good screener for BDD. So it's just a self-report. It's the Body Dysmorphic Disorder Questionnaire. And you could probably put a link to one
Yeah.
in the podcast so people will have that. But we were talking about, so what does it look like in treatment? So the first module is really about slowing everything down, helping them understand their BDD, helping them understand the obsessional sequence. So we go from the trigger to the obsessional doubt. Once you pass the obsessional doubt, my nose is crooked, we're getting into all the consequences. Now I'm thinking about what that means and what that means in my life and what that means in the people in my life. And then that creates a lot of disturbing feelings. Often it's shame and guilt. Anxiety is not the biggest emotion involved in BDD, although there can be anxiety. It's often depression and shame and hopelessness and guilt, feeling like there's nothing I can do to change it. Maybe I don't have enough money. My parents won't get me a nose job. And then the compulsion are mirror checking, researching possible procedures that you could use to correct it. Some people do self-surgery type of procedures
Yeah.
when it's that severe, using makeup to camouflage and contour, avoidance, positioning your body in a different way so people can't see a certain profile and see your nose in whatever way. There's lots of compulsions, reassurance seeking, and they can go on depending on whatever the defect is. So that's the obsessional sequence, module one. The
Mhm.
crux of treating BDD comes in modules 2 and 3. So in module 2, just like we do with OCD, we're looking at why the person believes that flaw. Why do they believe they have that flaw? And the reasons are very idiosyncratic. So for instance, right now, I have a lot of clients who believe their face or aspects of their face are asymmetrical.
Mhm.
And so often I've worked with a lot of adolescents and young adults showing up with BDD, but I remember it develops in early adolescence. So I want to know, when did this first occur to you?
Mhm.
And I'm going to tell you, this inverted camera, do you know what I'm talking about? Or you can mirror your image?
Yeah.
I mean, when people started inverting their image, when you invert your image on Snapchat or social media or whatever device, you look different, right? You're seeing yourself how other people see you. When you look in the mirror, you're seeing yourself how you see yourself. But when you invert that camera, and then that could be offsetting. Like, wait a minute. Now, there's some predisposing things going on before this ever happens, right? With BDD and with OCD, we believe there are already this vulnerable self theme in the background, right? This
Right.
feared possible self that's brewing. But you look, maybe you're already feeling like you are a little bit different. And now you look at the camera image, and that's where it all starts. So, wait a minute, something is different. My nose doesn't look quite right. I
Yeah.
remember them talking in the lunchroom the other week about that other kid that has this crooked nose. Maybe my nose is like that. And then start to grow the idea that this flaw is true.
Yeah.
Now, prior to seeing the inverted camera, now a person 13, 14 years old, they looked in the mirror a million times by that point, right? And they never saw that. They never saw what they now see. And then doubt begins to grow and it grows. And then I get confirmation as I go along, right? So, in the module 2, we are really looking at the reasons why. It's very important that we identify the doubt because the client with BDT will tell you, I'm just ugly. I just have low self esteem. I'm just grotesque. And if we go with that as the doubt, we're not going to find the reasons for it, right? We got to know the specific thing that makes them ugly. And then we talk about the reasons, and it's really Nicole, it's a beautiful dance because I'm not challenging. I'm just curious, right? It's the dance between me and the person with BDT. And I want to know what made you believe you know it's crooked. And it's a very validating process because often by the time a person has finished telling me all of the reasons they believe that flaw is true, I totally can see why they would come up with that conclusion, right? It just totally makes sense. And for many, it's the first time they've ever laid it out. And they've forgotten why they even started believing in the first place, right? Because you get so caught up in the moment and the day to day and gathering new information, you forget how it started. So that often during module 2, when a person has explored all of the reasons they believe their doubt to be true,
Mhm.
it starts to seem like, those are the reasons. Maybe there's something wrong here.
Mhm.
So we're starting to splinter and put some doubt into the doubt, right?
Mm.
It's really to get the person to see in black and white, because we're writing this down in black and white. Why do I believe this doubt? And then when we get to module 3, we're talking about stories. We know that you cannot have an obsessional doubt without a story. And all of the reasons that they have given me in our second session are informing that story. As a matter of fact, it is that story, right? It's the narrative unit that makes up the obsessional story. It's the thing that's going on in the background when they're looking in the mirror and seeing their nose is crooked.
Mhm.
It may not all be right there in conscious awareness. So we're bringing the subconscious conscious, like now we know. And we write the BDD story.
Yeah, yeah, yeah.
And we're letting it speak. We're giving it voice. And I'm going along with how it comes out, right? I'm just going along with the flow. And it really is a beautiful process. But we don't stop with the BDD story, right? Because we know there's an alternative story. And most of the time, the person with BDD knows there's an alternative story, but we want to draw that out. So then we write a counter story. We write a different point of view. And when we're done, like now we brought all this stuff to their awareness that they haven't thought about because what we talked about self-absorbed and imaginal absorption. When
Mhm.
somebody's absorbed, they're often absorbed into the consequences and how everybody's going to perceive them. I have to fix this. They never stop and slow things down to figure out, wait a minute, how did I come up with this conclusion that my nose is crooked or my face is asymmetrical? And by the time we write the counter story, 100% of my clients with body dysmorphic disorder will tell me that the counter story is more credible.
Wow.
100%. Now, not 100% say that they believe it.
Right.
Many will say that I still believe the BDD story, the story about that, and that's fine. But they can recognize that the first one sounds really far-fetched. All
Yeah.
of these, yeah, but we're just cracking the arm. We're getting them to look at what it is that you believe this thing about you. And then we're writing stories. And it really is this beautiful process. I call I-CBT a beautiful treatment. Never described any other treatment that way, but I really do think it's beautiful. It's validating. And it's something that most people resonate with, right?
Yeah.
And so at that point, that's really where we're breaking down the inferential confusion. Because remember, an inference is a conclusion we came to based on evidence and reasoning. And if there's inferential confusion, there's faulty reasoning. So the reasoning, while most of the time it's 100% factual, it's correct, right? It is just being applied out of context to that situation. We're
Yeah.
not arguing and saying your reasons are wrong. Like, there's nothing wrong with your reason.
Right. One of the things that I-CBT teaches is really how it uses the logic that makes us successful in other areas of life to give validation to the reasoning. And so, yes, we can understand and empathize and be like, not only that, but logically go like, yes, I get why you came to this conclusion. And yet, there's the difference of the conclusion that is based on imagination versus based in the here and now. One of the things I thought of when you were sharing about that counter story, and again, if you're new to I-CBT, this is probably going to sound a bit confusing, right? You're like, so I tell a different story. Like, if I could tell myself a different story about the way I look, then I wouldn't be here, right? We wouldn't be in this thing. So it can get confusing, which is why it can be really important to have a therapist to help walk you through this process. Because if it were as easy as just being like, not going to think that anymore. Then we wouldn't have OCD. We wouldn't have BDD. We would have a lot of things. But what I was thinking about was, so when Chris was on last year, he talked about how he was doing this group and he would sit in there and he would hear people sharing about their experience of BDD and he could not see it for them. It's a different story for the person with their own lived experience looking at what they see or are struggling with, but he couldn't see. And it started to fracture and splinter that idea that if we all relate on this and I literally can't see what they're talking about, that there's a possibility that mine isn't there either, right?
Absolutely.
And so that's where something like coming into that counter story and writing what we can engage with and what things we can track, because the inferential confusion, and I'm imagining it's similar in BDD, in OCD, isn't about everything in life. It's in these really isolated slices, right? And
Right.
so when we start reconnecting and grounding ourselves in what we can create in a counter story based in the here and now, though our visual processing about this phlegm might be off, we can still create counter stories that are based in reality because we don't have inferential confusion about everything, right? And so that is part of being able to re-engage your trust in self, your trust in your ability to read the here and now, right now. That common sense is such a huge piece of I-CBT treatment. And similarly, I don't necessarily call it a beautiful process, but I totally get what you're saying there. But I do kind of consider I-CBT treatment to be similar to a love letter to yourself in a way, because you're starting to accept yourself for who you are, whether it's OCD, where it's more ego dystonic, or BDD, where it's more ego syntonic. It's accepting yourself for who you are and learning
Yes.
that I can be me here in reality. It's not going to be perfect. It's not going to be all sunshine and daisies. It's not going to be all terrible either. And for the person with lived experience of BDD, and often with OCD and so many people struggling with different mental health disorders, that hope gets squashed so quickly. And so really this allows us to bloom more hope, and blooming, growing, that is a beautiful process. So I like the way that you've been able to share about that. And I think that's a really helpful way for me to think about then what that means when we think about applying I-CBT to BDD. So, in terms of applying I-CBT to BDD, that is a newer kind of area, right? And so, looking around and going for resources, people aren't going to see a lot of information on the application of I-CBT for BDD. And so, can we just start to brainstorm about some resources and where you imagine this going?
So, a great resource for anyone suffering from BDD or the family member of anyone suffering is the BDD Foundation. And they have a website that's out of the UK. They have a lot of information on there. They're not going to have anything on ICBT. It's pretty new in the field, but it's a good resource for information. So, I would definitely recommend people going that way. The IOCD app has a BDD page, and they can go that way. Again, there's not going to be any information on I-CBT. If you're wanting to know more about I-CBT for BDD, you can go to icbt.online, go under Find Treatment, and there'll be a list of treatment providers all over the world. And we are breaking it up now so that the treatment providers can say if they treat BDD. And so you should be able to find somebody. But if you see a provider in your area that does not treat BDD or does not indicate they treat BDD, you can still reach out to them because ICBT can be applied to BDD very similar as it's applied to OCD. So if they know ICBT, they should be able to modify that and help you. Those three resources. If you're a clinician and you're more interested, of course, it's the same website, icbt.online. We have consultation groups that are free the first and third Friday of every month. I have a small team of people who are in the process of rewriting the modules, the ICBT modules for BDD.
Mhm.
The first modules that were written in 2005 and were based on the original ICBT modules. So we're rewriting them to update them to the current I-CBT modules. And I'm writing a manual that goes along with it. All of that's going to be freely available. It's just a manual for the BDD aspect, right?
Mhm.
And it's growing. The number of providers, I think providers are, like you said earlier, a little bit scared to treat BDD. And I just want to encourage anyone out there who's practicing I-CBT, one, to screen every client you have for BDD because it might be there and you not realize, and it might even interfere with their OCD treatment. And two, to get involved in the consultation group. The manual and the I-CBT modules will be out by early summer. Pick up the manuals and at least try to treat it. The traditional approach is still there, and you have two approaches, right? So you've got I-CBT, you've got the traditional approaches, and I kind of even see that they could potentially, the traditional approaches are addressing the consequence of the doubt. So even after, if the doubt is resolved, there are a lot of other things that are comorbid with BDD that could be addressed with the traditional approach.
Right. Yeah.
I do want to say too, Nicole,
Yeah.
when we talk about the person imagining the flaw and how does that resolve, I believe that once a person stops doubting, that the visual processing clears up. And it's not just I believe that, I see that happening because clients who resolve their doubt no longer see their flaws. But there's research coming out this year from the Netherlands on fMRI studies, and this is for OCD, but we're still talking about inferential confusion, right? That's what we're treating in both OCD and BDD. So the research studies are coming out where they have compared I-CBT to exposure response prevention to see if there's a difference in an outcome, but
Mhm.
they've added another element. They've added fMRI pre and post treatment. What they have found through this research is that those treated with I-CBT, both groups, participants had this visual processing, sensory processing issues, disturbance, pre-treatment.
Mhm.
Post-treatment, the group that were treated with I-CBT saw improvement in their visual processing.
Mhm.
This is really exciting news because we're seeing a change in that visual processing. It kind of confirms the hypothesis that BDD and the doubting and the OCD and the doubting are causing the visual processing disturbance. And if
Mhm.
we're seeing treatment after, which anecdotally I am seeing with BDD, and we are looking at possible research to address this and explore this idea more with BDD, pre and post treatment fMRI, to see if what we kind of think might happen is happening. Uh,
Wow.
yeah. So there's a lot of research coming out. There's interest growing. There's information out there. Also, there's actually three videos. Lucy Grants and I did videos on BDD using I-CBT. So those are available on icbt.online in the video resource tab.
And again, we have the BDD conference coming up. And so, no matter where you are in the
Oh,
world, if you wanted to join in on that too, that could be a really helpful resource for learning more about BDD.
let me add this too about the BDD conference that's coming up. I really encourage people to attend it. There are going to be two tracks. So one track is for clinicians and the other track is for lived experience. And Chris Trosset and Robin Stern are going to be, and Scott Granite are all going to be in that lived experience track. So if you suspect you might have BDD or you know you do have BDD, I would highly encourage you to attend the BDD conference.
Yeah, that is a great point. You know, something that you said that's kind of just marinating for me as we're drawing to a close. As we take different evidence-based treatments that we know are indicated for certain things, but also part of the deal with I-CBT is it talks about this mechanism that impacts OCD and inferential confusion. And if inferential confusion is not isolated just to OCD, if we look at the availability of recognizing where inferential confusion comes up in other mental health presentations and what that tool can offer. Sometimes folks will go, you know what, though, I don't see enough research on this yet, and I'm not sure if we have a case for going, I see inferential confusion here in BDD, then part of our experiences clinically can help inform what needs to be researched further. What are our clinical questions? what do we need to see in the progression of looking at this research? And the research you were describing sounds really exciting. And so I think sometimes we wait for a certain amount of research to come out, but also research helps us as clinicians, but it doesn't replace our clinical training and what we're doing with the client in the room, because no one client is going to be the same. So we need to know and have the fidelity of the model, but we also need to know the person sitting before us. And so I think it's exciting to think about how much hope this could bring, particularly for the people that, as you so eloquently said earlier, are living with the experience and disengaging from life. They want their life back. And to have an option that increases hope, that can decrease that you are just this flawed, disgusting human being, that can get people to the point where they're saying, what's the point in living anymore? And saying, no, actually, there's some hope here. That's pretty amazing. And I'll be very interested to see where the research continues from here. But I love the idea, and I was telling you, Margaret, before this, that the more that I have treated OCD, the more you get a profile for what inferential confusion is. And so whether you're dealing with an OCD case or other cases, we're talking about the model and what can the model offer to OCD and OCRDs here. And so I really appreciate you helping me understand it, because I have a passion for all of our OCD fam here, but our OCD related disorder fam is just, it's sometimes feeling even more disadvantaged, because as much as there's a lack of understanding about OCD, there's even less understanding around some of these OCD related disorders. And so I super appreciate you coming in and helping invite me and the fam here into understanding how this application can provide more hope. I will put all the resources that we discuss, more information about Margaret and the work that she's doing. I'm excited to see what's coming with fMRI studies. Well, Margaret, this has been absolutely just a pleasure chatting with you, and I've seen you around because, again, fam, she's been such an amazing cheerleader that she's constantly I am just really humbled and honored by the different guests and the people with lived experience coming on and sharing and helping our family have more support and resources. And you're a huge piece of that, Margaret, and now you're adding to it even more. So thank you for sharing your voice with us today. We super appreciate your time, and this has been fantastic.
Nicole, thank you. This is such an important piece of my work, BDD, and I'm really passionate about it. And I was excited to be here today,
Oh,
honestly.
I'm so glad. Intrusive Thoughts. All right. So, what do you think, fam? I have to tell you, I'm really appreciative to Margaret for coming and spending time with us today and really helping me walk through what this looks like when we think about applying I-CBT to the treatment of BDD. And, we talked a little bit about mirror checking, and there's a lot of mirror work that can be done as part of the treatment process for BDD. And I started thinking about the inverted mirror and what mirrors reflect. And bear with me, fam, because I went to a special place. I kind of got to a philosophical place. But I started thinking about this older reading from Plato collected in his work, The Republic. And there's this allegory of the cave, the shadows, the way that we experience or perceive our environment. And when it comes to our BDD fam, I don't know. I felt like this really spoke to me in the way I'm conceptualizing BDD, in the imagination and in the experience and in the visual processing and all of it. So for today's intrusive thought segment, which is our application segment of the show, I'm going to do something a little different, and I'm going to share with us about this reading. So I'm going to put over on OCDFamilyPodcast.com the link to this write-up that I'm going to read, because I am going to read it from this write-up. I am not a skilled philosopher, but what I will say is this really spoke to me. So I'm going to read it to you, and I would love to hear your thoughts on it as well. So it talks about this allegory of the cave, which was presented originally in Plato's work, and it was written as a dialogue between Plato's brother. I'm going to botch this. I'm going to say Glosson. I'm probably mispronouncing that. Again, not a philosopher, but a dialogue between Glaucon and his mentor Socrates. And so this allegory talked about the imprisonment in the cave. Okay. And so, quote, Plato begins by having Socrates ask Glaucon, sure, we'll go with that, Glaucon, to imagine a cave where people have been imprisoned from childhood, but not from birth. These prisoners are chained so that their legs and their necks are fixed, forcing them to gaze at a wall in front of them and not to look around the cave, each other, or even themselves. Behind the prisoners is a fire, and between the fire and the prisoners is a raised walkway with a low wall behind which people are walking, carrying objects, or puppets of, quote, men and other things. So the people walk behind the wall so their bodies do not cast the shadows for the prisoners to see, but the objects that they're carrying, those do. Similar to how puppets kind of appear above the screen. You don't see the puppeteer, but you can see the puppet. You can see the thing that peeks above the wall there. And so the shadows of these objects were visible to the prisoners, and the prisoners cannot see any of what is happening behind them. They are only able to see the shadows cast upon the cave wall in front of them. They can hear the sounds of the people talking echo off the walls, and the prisoners believe these sounds are coming from the shadows. So Socrates suggested that the shadows are reality for the prisoners because, you know what? They've never seen anything else. They do not realize what they see are shadows of objects in front of a fire, much less that these objects are inspired by real things outside of the cave, which they do not see. But then there's this departure from the cave, okay? So Socrates then supposes that the prisoners are released, and a freed prisoner would look around and see the fire. The light would probably hurt his eyes, make it difficult for him to see the objects, casting shadows. And if he were told that what he is seeing is the real thing, instead of the version of reality that he has seen on the wall every time, he would not believe it. In his pain, Socrates continues that the freed prisoner would turn away and run back to what he's accustomed to. But slowly, his eyes would adjust to the light. And as I thought about this with the cave, if all you had ever seen and processed were shadows, which we can argue in reality are not the actual items themselves, but the image reflected in the absence and the presence of light, in this case, the fire, it'd be hard to believe that those shadows weren't the thing all along. It just made me think of our BDD sufferers, of our BDD fam. What they see, whether in the shadows or in the mirror or in themselves, well, as real as anything they've ever experienced, the shadow isn't the thing. And I think it's a powerful reminder when I even think about BDD through this lens of I-CBT, because whether we are talking about this quality of imaginal absorption or whether we're talking about visual processing differences, we see how much the story and the experience of the story can create meaning for someone. But similarly, illuminating and understanding that that story, those shadows, these flaws could be something else entirely. To tap into the doubt, to that possibility, I can only imagine how freeing that could be. So I'm thankful to Margaret for coming and sharing more about I-CBT. We've talked about resources, whether we're talking about the BDD online conference. I'm going to have the details over on the blog, Saturday, March 16th. If you can connect to the internet, you can connect to the conference, or whether you're exploring through your own treatment or trying to find a provider that does I-CBT. And I will note too, and I'll add this to the blog as well, like Margaret said, even if somebody doesn't treat BDD per se, I think understanding the concepts is pretty core to understanding where I-CBT could be useful. So I will shout out too that recently OCD Training School has launched a self-study program, particularly for folks that do not have providers that they can find in their area or with openings or that take their insurance. And if they want to look into that self-study program, they can check out OCD Training School. So I will put a link for that on the blog as well. But even starting to understand I-CBT better for yourself could be a really great resource for understanding how it could bring hope and offer healing for the BDD community. And with that, fam, thank you for joining me. And thank you that I am feeling better and I am looking forward to more hope and doing this journey with you because, fam, we're better together. See you next week. Thank you for joining me and our OCD family community. If you enjoyed what you heard today, please like and subscribe to the OCD Family Podcast wherever you enjoy your podcasts. Did you find this content helpful? Please consider leaving a review. The more people that know they're not alone, the better. For more information regarding today's podcast, please visit OCDFamilyPodcast.com and remember to join the email list while you're there. It will provide you with the most up-to-date information, resources, and the down low on the family chatter. Oh yeah, nothing says family like Margaret and me talking about BDD. That's right, I went there, and you can too at OCDFamilyPodcast.com.